The randomized phase 3 FLORA trial, which compared osimertinib to the standard of care first-generation EGFR inhibitors, erlotinib and gefitinib, and showed that osimertinib improved both progression-free survival and overall survival compared to the first-generation EGFR drugs. I think the FLORA trial really establishes osimertinib as a standard of care for newly diagnosed EGFR-mutant patients. And we also talked a little bit about some of the treatments, the combination treatment strategies that may potentially become a standard of care in the future, including the combination of EGFR inhibitors together with VEGF-targeted therapies such as bevacizumab or ramucirumab, as well as the combination of EGFR inhibitors and chemotherapy. Both of those strategies have shown promise when combined with first-generation EGFR inhibitors, and upcoming trials will be looking at those combinations together with osimertinib, and I think they have the potential to transform our standard of care. So I think a lot of exciting things to come still in EGFR mutant lung cancer, but for now, the main take home is that osimertinib is our preferred first-line treatment. I also touched on the fact that it's important to identify these patients early, because even if they're PD-L1 high, EGFR inhibitors are really the mainstay of treatment, and there's a risk to starting immunotherapy prior to the results of the EGFR testing coming back. We know that immunotherapy is not an effective treatment strategy for patients with EGFR mutant lung cancer, and additionally, we've also seen that the risks of the EGFR inhibitor, if started after immunotherapy, can be increased. So I emphasize the fact that it's important to wait for the testing to return and to treat EGFR mutant patients with the appropriate TKI and not with immunotherapy first line.